Hey guys, welcome back to the Pulling Curls podcast. Today in episode 177, we are going to talk about what happens right after delivery. Let's untangle it. Hi, I'm Hillary Erickson, the curly head behind the Pulling Curls podcast, Pregnancy and Parenting Untangled. There's no right answer for every family, but on this show, we hope to give you some ideas to make life simpler at your house. Life's tangled, just like my hair. Okay, today's guest is a nurse with 15 years of experience in the middle of the country, and she works at an LDRP there. I want to introduce labor nurse Jess. Do you feel prepared for your delivery? In just 3 short hours, you can be prepared for the confident, collaborative delivery you want. You'll know what to expect and how to talk with your healthcare team, and there are no boring lessons in this class. I'll use humor, stories from my 20 years in the delivery room to engage both of you. I love how Alyssa told me that she found herself laughing at things that used to sound scary. Most of all, you guys are going to be on the same page from bump to bassinet. Join the online prenatal class for couples today. You can save 15% with coupon code UNTANGLED. You can find the link in the show notes. Hey, Jess, welcome to the Pulling Curls podcast.
Hi, how are you?
I'm so good. I'm excited to be here. Jess has been a labor nurse for 15 years. So we've got lots of experience on this podcast.
Yeah. 15 years. It's been a really long time, so I love it.
What's the longest anyone on your unit has worked labor and delivery?
Well, we just had a gal retire in June, and she started in 1978. That's the year I was born, so 44 years.
Wow. Did she leave labor and delivery?
She worked, that's where she started, and that's where she worked the same job the entire
Oh, because you guys recover also. Because I was going to say all of our labor nurses, when they get to a certain age, just switch to postpartum.
Yep. No, she did labors that's
good for her.
She loved. Yeah, she was.
Or bad for her, depending.
No, she loved it.
Oh, that's good.
She was like PRN kind of like towards the end, but
awesome. Okay, so before we started talking, Jess and I noted a difference. So Jess works at an LDRP hospital. So explain what that is, Jess.
They come in, they labor, they deliver, they recover, and they're postpartum all in the same room. They never have to switch to a postpartum unit. So it's really nice because they don't ever have to leave. But we were kind of talking about like the recovery process is maybe like a little bit more relaxed at my hospital as long as our census is not super high. So some of the stuff that I might talk about might be a little bit different, or there might be time constraints like in a busier hospital or somewhere where you have to like switch rooms.
Is that normal in your area? Do a lot of the hospitals do that?
No, not really. Okay. There's another hospital in town that they have a labor and delivery and then a postpartum unit. I think most of like Lincoln and Omaha is probably labor and delivery and then postpartum.
Okay.
So it kind of just depends on the hospital.
Yeah. I've never worked at one, but when I started, like when I was going to nursing school, the smallest hospital in the area was LDRP.
Yeah, they remodeled it like in 2008. And I think that at that time there was like a big push for like the LDRPs. And so we're a town of about 60,000 and we have 2 hospitals that do deliveries. And so it works for us because we are a smaller hospital. But
yeah. So you got to think if a hospital has a lot of deliveries, if they need like 20 labor suites, those suites have to have a lot more equipment in them for labor and delivery than they do for postpartum. So they're trying to get a lot of people through. So if you're looking for an LDRP, you're going to want to look for probably a smaller hospital in your area, just to give you guys a heads up. That's what I think. Smaller ones tend to be LDRP.
Right. And we don't, we just don't have the volume, so we don't have to turn those rooms over, like they would in a higher volume hospital. So
yeah. All right. So guys, you might want to take a listen to a previous podcast that I did in the minutes right before delivery. And we stopped there with skin to skin. So baby comes up and does skin to skin with mom, if mom wants. Jess, do you think all patients love skin to skin?
I feel like even the ones that are kind of a little bit iffy about it, like during their labor, like once the baby comes out, like they're almost always totally fine with it. In my career, I've probably had just a handful of them that were like adamant that we take the baby right away and clean the baby off before we give the baby to them. But
yeah, a lot of times they'll do like 2 or 3 minutes of skin to skin. And then sometimes I've had patients that start to look really anxious just because they're like getting sewn up where, if they're bleeding, all these kind of different things. And they'll be like, can dad take her for a little bit? So what I want to encourage you guys is to just let us know if that's you, because we don't care if you don't want to do skin to skin. We want to encourage it, but I can also see that if I was getting sewn up, maybe was feeling a lot of cramping, maybe I wouldn't want the baby on my chest right then.
Yeah, right. If somebody is like bleeding or just not feeling really well or something, I mean, we're gonna see that, and we're gonna ask if like somebody wants to hold the baby, if we should take the baby to the warmer. But most of the time, yeah, they just want to snuggle with their baby. So
yeah. And like I talked about before, it is delayed cord clamping is a standard. But just how long do most of the doctors wait at your hospital?
Most of ours do 1 minute, but we do have one that does 3 minutes.
Oh, okay. Is that a doctor or midwife?
Nope, it's a doctor.
Wow. I know a lot of people want to wait till it stops pulsating, but that's, I don't know, 3 minutes almost seems stops pulsating for me when I've delivered.
Yeah, 3 minutes really sometimes is like a really long time, especially when you're like, I think we need to like do something more with this baby than just have it laying on mom. But yeah, sometimes 3 minutes is a really long time. But
yeah, so it's a standard of care. I think a lot of people are like, well, my doctor needs to do delayed cord clamping, but it's part of NRP, which is how we like resuscitate newborns. So don't worry about that. Everyone should be delayed cord clamping at this point.
I started in 2007, 2008. And I feel like we've always been doing like at least a minute. So I feel like, people have had that in their birth plans, and, it's, I think, been the standard of care where I've worked forever. So.
Oh no, it was like pulling teeth at my hospital. They were adamant that the baby was losing blood if it was above the placenta. We still have one who just holds the baby at the level of the placenta until he clamps it.
No, ours have been our providers have been really, really good about that. So.
Yeah. Okay. So I think a lot of times people get worried that they're just like stuck alone with this baby on their chest. But at least in every hospital I've ever worked at, there's a nurse for baby and there's a nurse for mom. And that first, it depends on how tight the staffing is. But at least in the first, till baby's stable, there's a nurse for mom and a nurse for baby. Is that true at your hospital too?
Yeah, it's usually like the charge nurse, or maybe like like if we have NICU nurse on the floor or something, that'll come in and recover baby. And if we're not super busy, usually the baby nurse is going to take care of that baby and fully recover it, do the beds and everything like that. So like a couple of hours. But if it's busy, then they might have to turn the baby over to the mom's nurse. But usually it's not going to be until after probably like maybe after the second set of vitals, I guess. So like 30, 40 minutes. So.
Yeah. I mean, it's just, staffing.
Right.
Is everything.
I mean, yeah. And it's either like we're not that busy or we're like swamped, and there's really no in between. But yeah, I mean, we're never going to like leave you like just alone.
Yeah. So most labor nurses know how to do baby. So if you have any questions about baby, you're always good to ask the labor nurse. But if you have questions about yourself, sometimes the NICU nurses are not comfortable answering those. Sometimes they are, just depends on where they work and all that kind of different things. So, but they can always get the answer for you. So you can ask either of those nurses about any question about either of you. Wouldn't you agree?
Right. Yeah. I feel like there's a lot of crossover, at least where I work. But like I said, we're an LDRP. So we kind of, I don't know, we just do a lot, I think. But
yeah. Well, especially that first hour, I think most people, well, I should say. So if you are just a baby nurse, you're really just not comfortable with adults. So, but they can still find your labor nurse too.
Right. And the labor nurse is probably going to be pretty close by because she's going to be doing pretty frequent.
Yeah. Vital checks.
Checks on mom and stuff. So.
Yeah.
Because I don't know. We do fundal checks every 15 minutes.
Yeah. So do we.
I mean, you don't really ever get to get out of the room too much, but
cleaning instruments is usually the only thing I'm gone for much. Sometimes I have to eat if we pushed for 3 hours. But
yes, that is like you walk out and you're like, shove your food in your face for like 5 minutes. But
yeah,
then but you're not really like out of the room for very long. So
yeah. So baby comes to your chest and then your doctor or midwife, whoever, is just going to take a peek at your lady bits to see if there needs to be sewing. I think a lot of people think that there is just like one type of tear, but there are really a lot of different ones. Wouldn't you agree, Jess?
Yeah, they can be like inside, they can be cervical, they can be, like in your perineum. They're kind of up by your urethra. Like there's lots of, and most of them are really like not very, it sounds bad to say that they're not very bad because I'm sure that they are to the patient, but most of them are pretty simple.
Yeah. And I've actually had skid marks. Do you guys ever call them at your hospital?
Yeah. I mean, I hate the term, but yeah, I feel like, yeah, especially on like the people that have had, multiple babies, but
that's kind of what it looks like. Like if you fall off if you're 8 and you fall off your bike,
like an abrasion, just like a scrape. But yeah.
And I will say that
they burn. They
yes,
burn
when you pee. That is alarming.
Yeah, I mean they definitely burn, but they heal really fast. So
yeah, and there's nothing to sew up, so they just take a peek to make sure it's not bleeding, that they don't need to do anything sewing. So yeah, that's part of their job, is to check that out. And then at some point in time, the placenta comes out.
Yeah, which most people have like that feels like so good once that's out. Like they just feel like complete relief after.
Yeah.
Like I feel like everybody's like, oh my gosh, like when that happens.
Yeah, because you are basically still pregnant until that baby comes out, or that placenta.
Right. Yeah. Like you just like all that pressure and everything, like it's just like it's all over at that point. So
Yeah, and if you're going natural,
then you start shaking. Like you're shaking. I feel like everybody starts shaking really at that point, though.
yeah, because their heater's gone.
They're
They have to create their own warmth. Do you have a lot of patients who keep their placentas, use them for different things?
I feel like maybe like 4 or 5 years ago, it was kind of more of a thing, but I don't think I've had anybody ask me in over a year.
Yeah. ACOG, I think it was, or it could have been the American Academy of Pediatrics, came out saying that placenta encapsulation, if you are GBS positive or have different bacteria on your placenta, or if the lady before you, because who knows how well they're sterilizing their placenta dehydrator, it can get passed to the baby through that. So I think since then, a lot of practitioners have been telling people to kind of avoid it.
Yeah. And I feel like that practice bulletin came out like probably about 2 or 3 years ago. Maybe.
Yeah.
That sounds about right.
Yeah. But I have had patients who wanted to put it in the ground and plant a tree on it. Some cultures like to do something with a placenta similar to that, as far as I know. So if that's something that you're thinking about, a couple of my hospitals had a boatload of paperwork if you took that placenta home. So that's just something to be aware of, to let your care team know in advance.
Yeah, definitely. I think because we do have like a consent form or something that we have to fill out. It's not like a ton of paperwork, but I know that we have to go over like the risks. And, I think if there's like a reason that we need to like keep the placenta like for pathology, then they won't let you take it, if there's like, some sort of a complication where the doctor wants to do pathology on it. But otherwise, I think that most of the doctors don't really care that much. But
no, my first hospital that I worked at, we donated all the placentas to a makeup company, which I thought was super weird. I mean, this was back in like 2001. I don't think they do that anymore.
No, I've never even heard of that.
Hillary, the Stone Age nurse. And then after the placenta comes out, they are going to start Pitocin. And I think a lot of people are like, I didn't get Pitocin, I didn't get induced. And I'm like, oh, you probably did.
I can count on less than 3 fingers, like the amount of people who have not gotten Pitocin, like post-delivery. And it's just because they, like straight up refuse, but with the agreement that they would take it if they needed it.
Yeah. And if you don't have an IV, we can give Pitocin as a shot, but it really is a standard of care just to make sure you don't bleed.
Right. Really, to help prevent that hemorrhage, which we absolutely don't want, because once you start the hemorrhage, then it's just a bigger process.
Yeah. And I think even midwives give Pitocin at home. I think, don't they?
I think so. I mean, home deliveries are not allowed in Nebraska. So I really don't have a whole lot of experience with home deliveries. Occasionally, like somebody will come in, that has tried a home delivery and, but we don't, like certified midwives cannot deliver babies at home here.
Okay. So they can only work in a birthing center?
Mm-hmm.
Okay. Interesting. I think that may be the rule in Arizona too. I honestly don't know, but we've definitely had patients who the home delivery didn't work out and have come seen us. So I don't know. Anyway.
Yeah. And just so I'm guessing, I'm guessing a lay midwife, I don't think that they would have access to Pitocin be able to give it because they're not like a actual provider.
Yeah. So Pitocin is given just to clamp down that uterus, make sure that you don't bleed. And we just give a little bit to everybody. Usually we give it in the first hour after the delivery and then you're done, hopefully.
We do like a bolus for 15 minutes and then it runs like the rest of the bag like over 2 hours. So usually by 2 hours postpartum, then it's done and we don't need to do it anymore. That's if they're vaginal delivery or C-section, like it's the same.
Yeah. Okay. So they've done your repair. You're all ready. We'll put the bed back together because even if you wanted to deliver in a different way, usually your doctor's going to want you to have you be in the stirrups to take a peek at your lady bits to make sure everything's intact. It's hard for them to do that if you're just like squatting. So
right. Yeah,
you're going to end up in the stirrups for them to just make sure everything looks okay, which would be important because you want to make sure there is always a chance that like you ripped to your rectum or you've ripped other places. So they just need to look at it really good. Wouldn't you agree, Jess?
Yeah, especially, I don't know, if you've got like a cervical tear or something like there's no way that they're going to be able to see that. Like just like a quick squatting look. I mean, they really got to look in there. So yeah, you don't want that going unrepaired. So
yeah. And frankly, after delivery, you're tired. You want to lay down. It's a great position to have baby on your chest.
Yeah. Oh, absolutely. I think at that point, most people want to be in the bed. Like
because the baby's out. They don't need to, everything's good. And I think a lot of people think I'm going to have pain, like labor pain after delivery. But I want to assure you that if you're going natural, once the baby is out, you are fairly pain-free. And then you get like a big contraction with a placenta, and then it is done. That's the beauty of it.
Right. You might be I don't even really feel, I didn't have epidurals with my kids, and I don't even really remember feeling even like tender or anything. I mean, just like when they were like looking to see if I tore, but I don't even really remember feeling like much of any pain. But I mean, you're also like jacked up on adrenaline and stuff. So
yeah, a lot of endorphins going on for everyone, and epidural or not, a lot of endorphins at that point. So it's great. And then we try and clean up your downtown area, your lady bits. We'll clean things off. And then some places put pads on you. I usually just put my patients on a towel at that point because it's hard to the pad doesn't stay in place. I don't know. What do you guys do, Jess?
Yeah, we've got like the cloth Chucks pad underneath. And then we have like an ice pack. That's like a pad sort of that we tuck up, by the vagina. That's kind of nice and cooling on the perineum. And then we usually just keep that there like during the recovery period when we're doing our fundal checks. And then we've got to weigh all that stuff.
Oh, so you weigh everything too after delivery?
Yeah, we put a new pad underneath mom and then the ice pack. And then we've got to weigh all that for our QBL.
Oh, goodness gracious. So there is a chance after you have a baby of losing a lot of blood. So what she's saying is like after delivery, they want us to weigh everything to see how much blood you've lost.
Like our initial, like we do our QBL, like with the physician for like what they had at the delivery, and then like our 2-hour postpartum period, then we weigh everything that like would have blood on it and then come up with like our final QBL. And then if it's over, I think 1,000, then we have to weigh everything for 24 hours.
Oh, wow. That's a lot. So anyway, that's just something to be aware of. A lot of hospitals do that. My hospital keeps trying to do that.
It was like a little bit of an adjustment, but it went pretty smoothly once we got used to it. But it was, after like so many years of doing it one way, it's kind of hard to shift your ways. But
it's true.
It is kind of amazing to see like what you thought things were doing, and then like really actually realizing what like the actual numbers are.
Yeah, I agree. That's good to have the knowledge. So then we put the bottom of the bed back together. If you guys don't know, the bottom of the bed comes off for delivery or whatever to use the stirrups. And then we can put the bottom of the bed back on. There's handles on the bed. The beds are multifunctional. So that's the good news about labor beds.
And while that's happening, your baby's still on your chest. The baby nurse is doing vitals, and, we've done, the 1 and 5 minute APGARs. And I don't know how you guys do your vitals, but ours are like every 30 minutes for 2 hours for your baby.
Every 15 here.
Yeah.
It's like every 15 for like an hour, and then it's every 30 for like, I don't know, seems like forever, but it's not.
Yeah. So ours were every 15 for an hour, and then that was it. But now they're every 30 for 2 hours. So
yeah. So we especially want to take baby's temperature, make sure that baby is adjusting to living in air and is regulating its temperature okay, listening to those heart and lungs, make sure there isn't like a lot of fluid in there. That's mostly what you're doing. And then Jess, do you have a problem if they stay skin to skin? Or do you have nurses that like to bring the baby to the warmer quickly? What do you guys do?
No, most of the time we just keep the baby skin to skin. Sometimes the moms and parents are really anxious to get a weight. And so, sometimes we'll take the baby over a quick weight and then maybe put a diaper on them so that if they decide to like go to the bathroom or something, they're not do it all over mom.
Yeah.
And then take baby back over and then tuck baby back in. So, but we don't usually do like the measurements and all that stuff over there until like way after. So
yeah,
the rest of the measurements, like the head.
I love it when they ask me how much the baby weighs when it's only been on their skin to skin. I'm like, I don't know.
Right. I'm like, I don't know. Like, what do you think?
So I actually do think if they want to know the weight, not everybody does, but if they want to know the weight, it's a great time to do it once we put the bed back together and we're kind of just scooching them up in bed, and then they can kind of like, get themselves comfortable. Baby can be at weight and then come back. So up to mom though, whatever you're comfy with.
If mom's had an epidural, then a lot of times the doctor will like to get the epidural out too. So like they're really fiddling a lot with moms. That is a really good time to take the baby for its weight and maybe put a diaper on, so.
Yeah. And then you just stay happily ever after. I love to do my newborn assessment on the chest as long as the baby looks good. I'll even do shots on mom's chest if mom's comfortable with that.
Yeah. And I love that when they are, because I feel like babies like settle down so much sooner because they're like right next to mom, and then they can just go right back to breast if they, have been breastfeeding or.
Yeah. I would caution you to make sure that you're okay watching the baby get the shots, because sometimes a lot of moms freak out because they have shot issues. So you can have us take it to the warmer for the shot, or we can do it on your skin to skin, just whatever you want. Just communicate your needs to us. I think that's so important.
Yeah. I know we've had some moms that like the best time that we can do the shots is when mom's up in the bathroom or shower after they've delivered, because mom does not want to be anywhere near the first set of shots. So
yeah.
We're pretty flexible. I feel like, we're going to do pretty much what you want as long long as it fits in what we, kind of have to do with the baby. So,
yeah. And then, of course, if anything looks funky with the baby, I take the baby over to the warmer. So, we're not going to be like assessing a real difficult problem while baby's on your skin to skin.
Right. If baby's like really grunting loud, which is kind of like when they're having, I don't know, some symptoms of respiratory distress or, like are not as pink as they should be, if they're kind of looking a little bit dusky, like I'm definitely taking them over to the warmer and getting a good look at them and, making sure that their oxygen is doing okay. If they're like kind of a little bit grunty, kind of intermittently, I'll probably leave them on mom's chest because I feel like sometimes they just acclimate better when they're close to mom. But if they're really grunting hard,
being prone, which is when you're on your belly, I think sometimes helps them get that fluid out of their lungs a little bit more too.
Yeah.
So I think a lot of people are like, oh, is the warmer in the nursery? So usually in the labor and delivery rooms, there should be a warmer in every room. And there's kind of like levels of care. So I am good to take care of a normal baby newborn and just a little bit past that. And then if it's anything like that, I call in one of the nursery nurses because I just want a second opinion.
Right. I agree with you. I don't really, if they really are acting funny or if they're like, especially if they're kind of like maybe like 36-ish weeks and like grunting, I'm definitely going to bring in a nursery nurse pretty quickly, probably because I am starting to kind of think like maybe this baby's not going to hang out in mom's room like all night. So.
Yeah. But sometimes nursery nurse comes in, she's like, she just does like a little oxygen and then she's like, there, he's good. You're like, okay, great.
Yeah. Yeah. Sometimes they just need to come over and do a little CPAP, which is kind of like when it's a little mask that goes on their face and kind of helps, hold those lungs open. And then they usually don't need it for very long. And then they can come right back over to mom and stay in the room. So.
Yeah. So it's really, what I want to caution you guys, it's really not unusual for baby to like, where we're like, what's going on over here? I just want to take a peek of them at the warmer because what is it? Like 10% of babies need a little bit of help at delivery. So what they say in NRP, or is it 1%?
I can't remember. I feel like it's probably more like 10%, but I don't know the actual.
I think 1% need just like a little bit of help. And then 1% needs like a little bit more help.
Yeah. I mean, there's not very often that I feel like we don't do much more than CPAP on like most babies. And even most babies, we don't even do CPAP. So yeah. I mean, most of the time, like your baby is going to be able to hang out with you, but don't freak out.
Yeah, it's not unusual at all. Not unusual.
No, especially if it's like if the baby's like a little bit like 36, 37 weeks, or if like you're a C-section. I feel like you're more likely to end up with a little bit of CPAP after delivery.
Yeah. And all that's very normal. Like it's a normal thing for us to do. I know it's unusual for you to see that the baby needs a little bit of help, but nobody really talks about, oh, my baby went to the warmer for 2 minutes after delivery. It's just very normal.
Yeah. And if they do have to give that CPAP, like you're not going to hear your baby crying because that mask is like over kind of tight. And so like, don't be freaking out. Like if like your baby was crying and then like you don't really hear it because they're probably kind of crying, but like it's really muffled sounding. And so like a lot of times they're like, oh my gosh, my baby's not crying. What's going on? And so, ask those questions, but like, don't panic. I don't think because.
Yeah. And then usually about an hour and a half in, we try and get our ladies up to the restroom. What about you, Jess?
I would say like we aim for about 2 hours, especially if they were straight capped, like sometimes the doctor will like cap them at the delivery or like right around the time of delivery. And so sometimes those ones we can kind of stretch out a little bit longer or if they've had a really like heavy epidural and they just don't have their legs back yet.
Yeah.
But I'd say like probably about 2 hours is what we aim for.
Yeah, that would be a huge benefit for you guys. Most hospitals, I think, really aim to get them up to postpartum within 2 hours because they want the labor nurse to take another patient is really why we're trying to do that. But also the other benefit is baby usually is super tired at that point. So it's a good time for everybody to nap in the new room. So I'm not saying that it's horrible, but we do kind of sometimes rush it more than I wish we did.
Yeah. And sometimes I wish that we could rush it a little bit more.
The grass is always greener. So your first trip to the restroom, especially if it's your first baby, is going to be kind of a big surprise. The nurse is going to go with you. Totally normal. That's her job. There's always a chance you could faint. What about you, Jess?
Yeah, I do feel like if somebody's going to faint, it's going to be on that first trip usually.
Yeah.
And there's going to be so much more blood than you were expecting. And like, we're ready for it and we're prepared for it. But like, you probably won't be. Like, you're just going to be like, oh my gosh, there's no way that's normal. And it most likely is, or we wouldn't be getting you up to the bathroom. So.
Yeah. We use a device called Sarah Steady. Have you ever heard of this?
I've seen it like on Instagram and stuff, but we don't have it. We walk you there.
It's like a a wheelchair with lifting butt flaps. So we just like scoot it in, you stand up, you get on it, we wheel you into the restroom, you stand up, we plop you on the toilet, we get it out of the way. Anyway, it's like a wheelchair that's more easy to use with the restroom, basically. But even with that, I'd use a Chucks like a diaper because when you get up, because of gravity, it just pulls all those clots and all the blood that's just been hanging out. It's good times. Good times.
Yeah, you're the first time you stand up, it's just going to like anything that's just hanging out in there, it's just going to come out and it's going to look like so much more blood than what you were expecting, probably.
Yeah. And your legs are going to be dirty. Like you are going to be dirty.
Yeah. Like that shower is going to feel like the greatest shower ever. I always felt like.
How long do most of your moms wait to shower, Jess, since you're in the same room?
Usually we try to get them up and shower like at that same time. Like we get them up, we empty their bladder, and then we try to get them into the shower, unless they're a C-section, and then it's 24 hours. But
yeah. So even an epidural mom, 2 hours later, you're trying to shower them?
If they got their legs back, we'll put a shower chair in.
Oh, that's nice. Okay. So at my hospital, I would say we aim for 12-ish hours or the next morning.
Oh my gosh.
Obviously, we're not going to wake you up at 4 a.m.
I cannot even imagine having waited that long.
Yeah. Although I basically do a bed bath while they're on the toilet. Like I wipe off their back. I get all the epidural schmutz off of them. I do their legs. I don't do their hair.
If I have somebody who like doesn't want to take a shower yet, or like is still pretty, like, I don't know, is like kind of fainty, I'm not going to put them in the shower because that hot water is definitely going to make them faint, or if they haven't like eaten or something like that. Or if they're a C-section, I definitely like really, try to like scrub them, especially their back really good, because it's like they get really sweaty on their back and it makes them feel really gross and itchy.
And then in my hospital, we take you up to a different floor and then you would have postpartum nurses, which are separate from labor and delivery. I mean, labor and delivery sometimes works postpartum, but postpartum nurses do not work labor and delivery. So it is separate in that way, I guess. And then you hang out there. So do you take all those patients or do you normally take labor patients? What do you do, Jess?
Well, I'm usually charged. So,
okay.
But before I was charged all the time, I preferred labors. So I often would like take the next labor that would come in, or, like I a million times would rather take labors than postpartums. That's my preference, but.
Amen. Oh, we didn't even talk about breastfeeding.
Oh, well,
it just occurred to me. So I think a lot of people expect this baby to just chug on your breast like a bottle at that point in time. And that's just not what it looks like.
No. Or also they like expect like to just lay the baby on the chest and like the baby is just gonna like latch on without any sort of like help or support or holding or anything like that. Like, and I mean, sometimes you'll have a baby that you lay it on there and then just all of a sudden you're like, oh my gosh, like look at that. But I feel like that's not really the norm, even though there's lots of YouTube videos out there saying that this is what babies do.
I know. The Lamaze one about like, if you don't have an epidural, that baby's going to army crawl up to you and it'll find your nipple just like a kangaroo.
Yeah. I mean, like I have seen it happen that way, but it is definitely, I don't think, the norm.
Yeah. I agree. And I caution moms, especially because a lot of times we'll go skin to skin, they cut the cord and then they're like, oh, should I breastfeed right now? And I'm like, just love your baby for a little bit. Like you don't need the pressure of breastfeeding until I've like gotten you set up in your bed.
Yeah. I feel like most of the time the baby is not even really that interested in breastfeeding right away. Like they've just been born. They're like still like acclimating to life.
Yeah. Breathing.
Right.
I mean, breathing is a big deal for them. So
right.
I agree. And I will always caution moms that having the baby skin to skin is it's a turn on for your breasts because it tells the breast baby's here, you're smelling the baby, you're loving the baby, like all of that gets your hormones going to say make milk.
Yeah, like the vernix and all that stuff, like any just having the baby's skin is gonna like help, and then but babies are gonna like, I mean, I feel like most babies are gonna start acting hungry within like maybe 30-40 minutes.
Yeah. And then they're going to eat and they're going to think about life. Like they're going to do 2 sucks and then they're going to be like, rough day here, mom. And then they'll take a suck and then they'll go to sleep and then they'll take a suck.
Yeah. Or you'll have one like who they just like literally like eat nonstop for like 2 hours too. Like I just feel like
right.
All of that is normal. Like all of that is normal. Sometimes like, I don't know what you guys do for your like blood sugars, because I feel like that's kind of important too. Like that parents know that we may be having to poke their baby for blood sugars. So like if mom is like
so usually we do that if mom's diabetic or if baby's big or baby's small.
I'm trying to think like if you haven't had any prenatal care, which I'm assuming if you're watching this podcast, you probably have had prenatal care, but if they had, there's certain like risk factors that will do blood sugars on them. But usually we wait, I'm trying to think, it's like maybe 90 minutes after birth or like 30 minutes after the feeding is when we would.
Okay. Yeah.
Do our blood sugars. So
and we have to do like 3. What do you guys have to do? Like once you start, it's 3.
It depends on their risk category. So if they're like a high risk newborn, which is like an S, like a small baby, or I think like a less than term baby, or I'm trying to think, and it's for 24 hours actually, that they'll get blood sugars, and it's like, and they have to have at least 3 good ones before we can like test them. So it could even be longer than 24 hours, but at that point they're probably going to be in the NICU.
Yeah.
And then for like a diabetic mom or like a big baby, those ones are 12 hours. So it usually ends up being about 3, but again, it has to have like 3 consecutive good ones.
Yeah. And babies' blood sugars are different than moms. We're just looking for, what's the number you guys are looking for, Jess?
Our first one has to be above 40, and then the consecutive ones have to be above 45.
Okay. Ours is just 40. If we want 3 above 40, basically is what we're aiming for. So blood sugars, not unusual. And also sometimes if the baby just looks kind of jittery or something, we'll just be like, I'm just going to take a blood sugar just to make sure.
Right. Yeah, we do too. Even if they don't have any other like risk factors. And usually it's fine, because usually it's just like they're, have an immature nervous system, and they just sometimes have these newborn jitters, but we want to make sure that their blood sugar is not like below 40. So
that's a simple thing to fix. Yeah.
Right. Which we fix it by feeding them. And then I don't know if you guys have the glucose gel.
I love it's all so confusing. I miss just putting a sugar bottle in the baby's mouth from back in the day. But
yeah, we've got and then we've got like donor milk that we can use too.
Yeah.
So
if mom's not up to breastfeeding,
if they are really wanting, if they're really wanting to breastfeed and only want their baby to have breast milk, like I know a lot of hospitals will have donor milk, that's an option. So
yeah, donor milk's FYI super, super expensive. Although I think a lot of hospitals end up kind of getting it donated to the hospital. But if you were to buy donor milk,
our foundation
makes sense.
Covers it or something. And so I don't think it's like it's a cost to the patient for us, but I don't know. It probably depends on the facility. So
I'm sure we try and bill your insurance because, we will. Yeah. But if you want a formula feed, then we would just pop a bottle in the baby's mouth too. Like there's lots of options. And you guys just...
Right.
So my number one tip would just be to communicate what you're feeling, questions you have. We'd love to answer questions. What are your tips for after baby's born, Jess? Right after.
Well, just enjoy your baby. Like just enjoy your baby. Don't feel like you have to do this or like because you read on some, I don't know, like web page or, that you need to have the baby eating by this time or you're not going to make any milk, because that's not true. Like as long as you get the baby eating at some point, within an hour or 2, like you're going to be fine.
Or 4 if baby ends up going to the NICU, like you're going to be fine. We can always hook you up with a pump. There's other things we can do. There are no hard and fast rules.
No, I feel like probably most of the nurses that I work with and that I've encountered are super flexible and are going to do whatever we can within, like reason to help the mom and that baby have like the best experience that they can, whatever that looks like for them.
Yeah. I do think a lot of moms feel a lot of pressure, like they need to learn everything about the baby right then. They need to do everything for the baby right then. They're just feeling like I need to feed, I need to do all these different things.
Right. And I feel like a lot of them feel like if that baby, like I feel like the first feeding either goes really, really, really well. And then the second feeding doesn't go as well. Or else the first feeding doesn't go that well, but then baby kind of figures it out. Like, I feel like it's kind of one of those 2 options. And like when that happens and the baby has that feeding where the baby doesn't eat that well, they feel like, oh my gosh, like I thought this was going to be something different. And like, then they put all this pressure on themselves, and like, it's going to go up and down and up and down, if you're breastfeeding. If you're bottle feeding, even sometimes they do weird things.
Yeah.
So
just love them.
Yep.
The love you have is actually one of the best things to turn on the milk, versus like freaking out is not one of the best ways to turn on the milk.
Yeah. I feel like the same thing, like when you're in labor, like, just like when you start freaking out, things shut down. It's kind of the same way, like postpartum too. Like when you start, which you're going to freak out, like everybody does. Like I remember being in tears, like at that 48-hour mark, like with all of my kids, like it's like, oh my gosh, like like that's normal, but like try really hard just to relax and just take things as they go.
Yeah, that's great advice. And if you're feeling something weird, let us know. If you feel a gush of blood, if you feel lightheaded, if you feel anything, and we can either say, yeah, it's totally normal. We'll check, make sure everything's fine. We didn't even talk about fundal checks. I'm a mess today.
Right. I mean, I think we briefly touched on that you're going to get them every 15 minutes, but I think that's all we talked about. But yeah, like the fundal checks are fun. I feel like people hate them. but they're pretty important.
So it's where we push on the top of your uterus, we stabilize the bottom of your uterus, and we just gently make sure that the uterus is firm. And then usually, I got to say, in that first hour, I do push down just a little bit every single time.
I know that they say like we're just supposed to kind of check for firmness, but I feel like if you don't really like, I don't do like a super vigorous massage unless like I have to, but I do like a little massage every time that first hour, because otherwise you end up with the clots that like all of a sudden you've got a really boggy uterus.
Yeah. So, and we're just doing that because your uterus is like a popped balloon, and it's got to like fold in all its sides on itself, put direct pressure on the placenta area, and then just, go back to the way it used to be. It's slowly going that way. It's still really big though.
Right. You're gonna look still like your belly. You're still gonna have a belly after you have your baby for a while, probably.
Yeah. And we do that about every 15 minutes. We'll push on your uterus, I think for the first 2 hours at most hospitals. And then every shift after that for us.
After that, I think it's like every 4 for 24 hours. And then like probably once a shift until discharge after that. So
yeah. But if at any point you start having gushing or anything like that, you always want to let your nurse know, because there is a real decent chance of a hemorrhage at any point in time there.
Right. Yeah. I've seen it happen like a day of discharge, or, people have gone home, and then that's when they start hemorrhaging. So if you start passing really big clots, like at any point, or even when you go home, like you need to tell somebody.
Yeah. All right. So that's life after delivery. And honestly, you don't need to know to do anything, because your nurse is going to do absolutely everything for you. She is going to spray off your bottom. She's going to help you get up. She's going to help position the baby to breastfeed. She's going to check your uterus. You just lay there and love your baby.
The mom's nurse and the baby's nurse, like for probably the first, I don't know, at our place for the first 2 hours, like they're going to love on you. Like they're going to take care of you. And like, you're going to have like probably the most attention that you're going to have in the entire hospital in those couple of hours, I feel like, afterwards.
Yeah. Cause essentially you're supposed to have 2 nurses in that room for those 2 hours, just making sure that everything's okay. Just because it's a high risk time for both of you, baby or mom. And if one of you has an issue, the other nurse needs to take the other patient.
Right. Yeah. You're not going to have that much like attention on you for the rest of the time. After that, it's completely different. But yeah, this first couple of hours, just really, that is like probably the best time to ask a lot of questions, because you're going to have your nurses like at your bedside there, like not maybe the whole time, but like they're going to be really readily available.
Yeah. And a lot of times we're doing like mindless work, like cleaning things up. So if you have questions, we are happy to answer those while we're just like doing housekeeping's job, really.
Right. Yes. Lots of cleaning in this.
I bet in the LDRP, does housekeeping come in then at some point and clean up the room?
Not usually. Not unless there's a real big mess or something. And then sometimes, usually it's all on us.
I'm not sad to leave the mess behind. I think that's my favorite part of leaving the room, is that they get a nice clean room, clean bed, all that kind of different thing. I should also mention that you are allowed to eat once baby's out. So some people are super hungry. Some people aren't. Would you guys feed them at your hospital? What do you do, Jess?
Well, so I work sometimes days and I work sometimes nights. And so nighttime, we're pretty limited. Like we don't have like a cafeteria that's open, or, any way to get like cafeteria type food. But our galley usually has like some sandwiches and some kind of simple stuff. We can make toast, and, we'll get you like a little juice cocktail and set you up. Like you're not going to starve if you deliver overnight. But during the day, then we'll get their diet order put in, and they can either order food for themselves and their, support person, or else they can run out and get food or have it delivered. They're on an unrestricted diet unless there's some reason that they're not at that point. So they can eat pretty much anything that they want at that point.
I do like to start small. I'm like, let's have a cracker before you eat this Mondo burrito. Let's just make sure that stomach is going to tolerate you.
Yeah. Especially if they were a C-section.
Well, yeah, for sure.
I do really try to have them like, we don't have any restrictions. Like we can feed them whatever they want after their C-section, after they come back. But I do try to like have them like, hey, let's maybe start with some toast or crackers before we, order a cheeseburger.
Yeah.
But I feel like most of the time,
they're not.
Even with C-sections, I feel like most people tolerate their diet afterwards.
Yeah. Ours really depends on the doctor. So we had some that were like, whatever. And some that were like, clears for 12, then soft. And I was like, oh my gosh.
Oh no, our orders are just pretty much they all are all the same for everybody. So that's super nice, because that would be a lot to keep track of. And
yeah, it's annoying. So, all right. So that's life after delivery. This was just to give you an idea of like what goes on. I'm not saying there's absolutely anything. There's nothing you have to do besides be the princess of the labor room. That's all we want from you.
Yeah. I love recoveries. I don't know. And I love going for babies. Like I love being the baby nurse too. Like that's probably like one of my favorite things. I love going for babies.
I love everything till we have to get them up to the restroom because I had so many patients faint at my first hospital. I'm always like, oh, please don't faint on me. But with the Steady, if they faint, I just wheel them back to their bed. So it's fine.
We've had like a group of fainters like recently. And so, yeah, like when you're talking about that, I'm like, that would be really, really nice to have. But
yeah, it's not unusual. And if you feel like you're going to faint, say something.
Yeah. If you start seeing stars or anything weird, like if you feel fuzzy, cottony in your head, like definitely say something
And take it slow. Because some people like get up like, I was a marathon runner until I got pregnant. So I'm just going to run to this bathroom right now. And I'm like, oh no, we're going to test each leg. We're going to take some deep breaths.
Yeah. And so I work at a place where we don't have the Steady and we have to you walk to the bathroom.
Yeah.
And so if you have any of that epidural left in your legs, it's going to be in knees. And so like, don't bend your knees that first time up. Like we're going to help you get there. Don't try to get up like on your own.
No.
Like ever for that first time.
Yeah.
Like don't be like, oh, I really got, and like, just like, don't just be patient, wait for your nurse. But
yeah,
like if you make a mess, whatever, like we have seen messes before. So we'll clean that up. Like, but do not get out of bed on your own.
Yeah. Amen. All right. That's life after delivery. If you guys have any questions, come find us over on Instagram. I'd be happy to answer some. Maybe we could even do a more in-depth one if you guys have questions about something specific. Thanks for coming on, Jess. I appreciate it.
Yeah. Thanks for having me.
I hope you guys enjoyed this episode. Jess has so much experience. It was fun to have her on, and it's interesting to see how different hospitals do different things. I, like I said, have never worked in a hospital where you labor and deliver in the same room. It seems like most hospitals are finding it's more economic to have postpartum rooms separate from labor rooms because labor rooms need to be bigger, yada, yada, the whole finances of the thing. But just interesting. And like I said, this isn't giving you information for anything that you need to do. You really are just the princess at that point and just love that baby. What an exciting time. I cannot wait for you to have your baby. And stay tuned. We've got some fun episodes coming up. Next week, I am going to talk about all the things I did as a mom that everyone else hated. So stay tuned for that one. And then after that, we're going to talk about what to do if you are afraid of C-section. So don't miss those episodes coming up. Thanks so much for joining us on today's episode. The Pulling Curls podcast grows when you share us on social media or leave a review. If you do, please tag us so that we can share and send you a virtual hug, which frankly is my favorite kind of hugging. Until next time, we hope you have a tangle-free day.